Good morning, everyone. Thank you all for coming. It's my honor and privilege to introduce our guest speaker for today, Dr. Paul Mayo. Dr. Mayo is the Academic Director for the Division of Pulmonary Critical Care and Sleep at North Shore LIJ Medical Center, part of the Northwell system. He's also Professor of Medicine at the Zucker School of Medicine at Hofstra. Dr. Mayo is no stranger to us. After obtaining his MD degree from Cornell Medical College, he went on to complete his residency right here at Roosevelt Hospital. He subsequently completed his pulmonary fellowship at Bellevue and stayed on as an attending physician on the chest service at Mayo. He subsequently embarked on an illustrious career as director of the medical ICU at Beth Israel Medical Center. He established one of the earliest simulation programs in the country at Beth Israel, some of the earliest papers on the effects of simulation on medical education. He has trained hundreds, probably thousands, of house officers, residence fellows, including our very own Dr. Gopal and others, and many of our former residents who've gone on to become fellows under him. His dedication to critical care education and his mentorship has really jump-started the careers of many pulmonary critical care physicians, including myself, and I'm deeply indebted to Dr. Mayo. Dr. Mayo has established himself as one of the most eminent figures in the practice of modern-day critical care. His tireless work through the American College of Chest Physicians has been instrumental in establishing and advancing the field of critical care ultrasonography throughout North America and the world. He's a senior editor for seminal textbooks such as Intensive Care Medicine by Irvin Rippey and Mayo, as well as critical care ultrasonography. Dr. Mayo lectures around the world, so we're very lucky today that the godfather of critical care ultrasonography returns to Roosevelt Hospital on Valentine's Day to speak about his love for ultrasonography. His topic for today is critical care ultrasonography for the evaluation of hemodynamic failure. Thank you, Dr.
Dr. Matthews, otherwise known as Joe, is this a 15-minute lecture or a half-hour or a 12-hour?
Whatever you want.
All right, about an hour?
Hour, yes.
Hour, okay, good. So let's see, I'm looking around. Dr. Butyman, nice to see you after all these years. You're PGY 41, I think. I'm a PGY 39, yes, okay. And Dr. Zucker, thanks for coming over. I'm looking around for other people with gray hair, and I'm sure Dr. Citron, he trained 2 years behind me, all right? And then I see the only person of my generation who looks exactly the same. Dr. Shapiro? Yeah, you just don't change. And Dr. Shapiro, I got to know you as you were chief resident over at Bellevue in the harsh old days. And you were the nicest chief resident I ever met over there. All the others were really mean. Okay, and then I trained here 79 to 83, 4 years. And it being Valentine's Day, I'm proud to say that I met my wife here. And she was my chief resident, Charlotte Gillespie. And if you go upstairs, my son, who's now a fourth-year medical student, one of my sons, he looked at these old pictures on the wall he set up there, and he said, "Oh, there's Dad and Mom." So I was like waiting to hear from him. Like, maybe what was it like? He said, "Dad, you had a lot of hair." It's only comment. Anyway, she was the youngest chief resident in Roosevelt history. She was 23 when she was a chief resident here. I was her underling for a while. Okay, I still am. And you may notice that I've had a metamorphosis from a city biker. I took my city bike pass from Met down here, and then I promised my wife that I would put on a jacket. So now I've had a metamorphosis into a serious speaker. So, being a serious speaker, why don't we talk a little bit about ultrasonography, which frankly, due to the influence of Joe and Big G uptown, this is bringing coals to Newcastle, right? That ultrasonography has a lot of utility over here uptown in unit function, Correct. Yeah, you've integrated it very effectively. Joe's been in a lot of the courses as faculty, et cetera, et cetera. So you're a respected colleague in the ultrasound working group. Okay, yeah. So let's talk about it a little bit. And I'm going to try to convince you that you really will be a different type of doctor in the ICU if you have full mastery of general critical care ultrasound, but we'll focus primarily on its utility for assessment of hemodynamic function. So what is critical care ultrasonography? What is it? Well, it's any aspect of ultrasonography that you might think is relevant to emergency medicine or ICU practice. It's a very, very broad topic. And where do you do it? Well, you do it wherever you take your machine, and the modern machines are eminently portable. So it's done in the ED, the ICU, and the rapid response team response. Really, anywhere there's a person who's critically ill, where you can bring a machine, which is virtually anywhere now. And who does it? Well, ED, intensivists, NPs and PAs are now, at least in our system, actually all over the United States are picking this up big time. And when? Immediately, repeatedly, in a goal-directed fashion, and very routinely. Okay? Why? Well, you don't have to question that ultrasonography is fully validated. It's been widespread use since the first 2D machines came out in about 1980 or so, the commercially viable machines. And radiology and cardiology have done all the hard work in validating that when you look at a kidney, there's just no question about that. We don't have to think, oh, what is it good for? It's good for looking at the inside of the body. So they've done the heavy lifting, and we're sort of just taking advantage of 30 or 40 years of their good work. I'll inform you that anyone in this room, this is not rocket science, can become quite skilled at this discipline. And you have to distinguish between what we do, which is immediate point of care ultrasonography, and consultative radiology and echo, where you call for a super expert to come and do it for you. Okay, so they're somewhat different, and it really has common sense application for critical illness. Why? Well, because if you order a test from an expert service, consultative service, there will be always a delay in execution of the test, always. The second thing is that examination, which is usually done by a technician, not by the expert, there's a delay in its interpretation. And then there's delay in getting the result to you. And then there's sort of this odd issue, which is that if you know all aspects of the case, because you're the primary care provider for that patient in the ICU, you're not clinically disassociated from the patient. You know what's going on in a global sense, whereas the reader downstairs is just looking at these images. Okay, so, and the other thing is that our expert colleagues, their systems are really only set up for one-time examination, not several exams in a day, for example. They just can't do it. And because technicians do their examinations, at least in the United States, not so much in Europe, the examination is mandated to be complete, all image set, because the technician is locked into that. That's very different than what you'll be doing at bedside. And the basic principles are very simple. You do the exam, you interpret the exam, and you immediately apply the results to the bedside of the patient. And there's nothing wrong with doing a limited exam that's goal-directed, and there's nothing wrong with a patient who's in a shock state, and you start the dobutamine, and you check again 10 minutes later to see if it works. And then there's a worsening later in the day, check again with the echo. So the idea of repeated goal-directed exams is embedded in critical care ultrasound. There's a roadmap for any of you who are interested. This is the one that still is regarded as the foundation document by a lot of the big organizations who write guidelines. So take a look at it. It's a very simple roadmap that this would be the minimum knowledge base, cognitive base that you need for mastery of this field. And if you want to add other stuff, please do, okay? So this then gets to a more sort of organized acronym. Joe, would you be willing to call your approach in the ICU as a WUBU approach, as in whole body ultrasonography? Absolutely. Yeah. So that's what he does and Big G do all the time, WUBUs. Okay, and a WUBU generally includes echo, 5U, obviously lung, some limited abdominal, very goal-directed, always possibly a full DVT study. And there's strong logic to using this approach for evaluation of cardiopulmonary failure, as well as a lot of other reasons in the ICU to use it. This is not a new concept. It was fully described by a guy named Daniel Lichtenstein, who did a lot of other work in the 90s on ultrasound, where he and a guy named Olivier Axler, both French, they went and they just did this on a whole bunch of patients, and they found, to their concern, that they found a lot of new stuff that was not detected by standard evaluation, by history, physical lab values, things like that, and x-rays. So this goes back more than 20 years as a concept. Does it work for hemodynamic failure? The best article to look at there, if you want really to be convinced, is the Italians are dominant ultrasonographers. They're now the big boys and girls in the field. They publish a lot. So this guy Volpicelli, he says, all right, let's take 108 patients with what he called undifferentiated hypotension. That means they don't have a stab wound in their chest, right? It means they're medical hypotension where the team's not entirely sure immediately what's doing it, not trauma cases, okay? So then he did a WUBU on these patients, by the way, without any knowledge of their history and physical, very constrained study. And he found when the final diagnosis was met by a team of experts at the end, blinded experts at the end of the discharge, of the hospitalization, 100% of the time, the WUBU exam said what was the cause of the hypotension, 100%. Okay. And there are multiple other studies that show the same. I give you a little reference by some Scandinavians that also indicates that if you do this, you find stuff that you don't find otherwise immediately. Okay, so literature's pretty good. So we'll keep it simple. When you have a patient in shock, we would use 5 standard views, correct, Joe? Yeah. They're well-defined, parasternal, long, short, apical floor, subcostal, IVC. Other aspects of WUBU are added as needed. So let's see if I can convince you why this is a good idea to do. The history and physical is always done. Ultrasonography has no merit unless you use the basic tools of history and physical lab values. But then once those have been achieved, what I would posit is that everybody should have a goal-directed echo. They're so easy to do if you know what you're doing, if you have a machine. It's just to be standard in the industry, and I'm going to try to defend that position for you. So, one reason to do this is that periodically, you do this on all your patients in shock and ICU and ED, you will find occasionally, not frequently, an immediately life-threatening condition that if action is not taken right away, the patient's gonna be dead, as in the morgue, okay? Is this common? Joe, is this common in your practice? No, but you find it sufficiently that that's one indication for immediate echo. There are many causes for this, and echo allows you to identify this subgroup right away so you can take action. Delay threatens the patient's life in an immediate sense. So let's look at a lot of cases. Now I'm going to assume that some of you, because you rotate through the ICU for the house staff, right, particularly, you're going to have seen some of these images. So this is not a didactic thing like, what is this? Or, like more, I'll give you some examples. This lady was 57. She had COPD exacerbation, no big deal, you know, approaching extubation decision, et cetera, et cetera. And then all of a sudden, over a 30-minute period, she started to get hypotensive and she became mottled. She was like purple, you know, more and more hypotensive, escalating doses of norepinephrine. We had no idea what was going on. So naturally, the fellow says, let me take a look because it's undifferentiated hypotension. We can see here an apical 4. Let me see, do I have an arrow here? Or yeah. Can you see it up there? Yeah. And you see there's a defect in the septum up here, which the fellow noticed and turned on a little bit of color and became concerned there was acute VSD. What? Okay. And then finishing the exam with a subcostal view, there was a pericardial fusion with marked compression of the RA3 wall with something pericardial fluid. And when the dust is settled, we called immediately for, the IBC is not relevant here, we thought the patient had somehow developed an acute hemopericardium for no reason. There was no time for official echo. We called the cardiac surgeons. They came up, and those are the real doctors. You know what I'm saying? They were like animals. They had a balloon pump in this guy. Forget all the sterility. They just wore gloves. And within about 3 minutes, I was stunned. And they took her down to surgery, and they found that she had a perforation of the myocardium and a VSD, and she had a silent myocardial infarction while she was on the ventilator because she was sedated. We didn't know what was happening. And the patient actually survived. The patient was the cousin of a person on the board of trustees, and we got a new machine on this. Right. Goal-directed echo saved this patient's life. So then, why not do consultative echocardiography in this type of patient? Well, the same argument. They can't come right away. They're experts, but they can't come right away. When they come, the technician does it. There's a delay in interpretation, delay in communication of results, and problems with clinical dissociation. And, you know, so I remember in this case, it was when I was at my new job, the cardiac surgeon didn't know us yet, right? So get an official echo. I said, why don't you come up here and look at it yourself? Which they did. And they said, we take action based on what you guys do from now on. Okay, case number 2, she came in with severe shortness of breath, elevation of blood pressure. And the emergency department had done something called an X-ray, chest X-ray, okay, which no longer applies if you're skilled at lung ultrasonography, and it was underpenetrated, rotated, supine, nonsense film, right, that tortures us every day in the ICU. What's that showing? Well, get out the portable CAT scanner, which is called an ultrasound machine. And it was read as consistent with CHF. So they say, hey, I guess we better give her diuretics. Okay, that was reasonable based on their interpretation. And then maybe we ought to, because of a history of high blood pressure, let's control that with some nitroglycerin. Oh, but patient's getting hypotensive. Let's start a pressor agent. Made sense. Cardiogenic shock. What? CHF. And we came down. And here we have end-systolic effacement of the ventricle. The ventricle is very small, and at the end of systole, in the parasternal short and long, there is no blood left in the ventricle. This is known as a hyperdynamic pattern, confirmed with the apical 4. And for those of you who have some interest in Doppler, it had the dreaded dagger-shaped configuration of an outflow gradient indicating a marked left ventricular obstruction during systole, physiologic. And to no one's surprise, the patient had a very, very small IVC. Okay, I'll show here, virtual IVC. So what had happened, of course, was that the team downstairs had said, CHF and hypotension, start all these things. And instead, the patient required counterintuitive treatment immediate volume resuscitation, immediate discontinuation. They were still using dopamine at this time. Immediate use of phenylephrine to increase afterload, to dilate the ventricle a little bit, and a beta blocker. And goal-directed echo interrupted a death spiral on this patient. What can you say? If it hadn't been done, the patient would have died. Just to belabor the point, she was 35. She collapsed in a supermarket, 24 weeks pregnant. Dr. Shapiro, you don't like these cases. Pregnant woman is critically ill. You wrote a nice review article on that subject. Yeah, I remember. Yeah. So she came in with profound hypotension and hypoxemia. All right. She was moribund, literally, and the fellow had the presence of mind. Let's do an echo. And Dr. Matthews, do you forgive the fellow for being off axis here on the apical 4? Because they had a nervous breakdown when it's out. No, this is an instantaneous diagnosis of a very large thrombus in transit. And the patient was already hypotensive. If that got loose, the patient would have died immediately. And a little bit later, once we settled things down, we saw residual thrombus in the femoral vein. So this was, TPA was given with some trepidation in the pregnant patient, and she actually survived. And about a year later, I was bicycling up First Avenue by Stuytown, and I looked over and I saw her, and she was pregnant again. And I said, I hope she's on, anticoagulation. I'm sure she was, but anyway. So if there'd been a delay, the patient would have died. So that is one of the arguments in favor of doing this in everybody. Occasionally you find the hot stuff, right? All right. Now, a key question that comes to my mind when I started this, can the interns in this group become proficient in goal-directed echo? And the answer is unequivocally, definitively, yes, yes, yes. And I gave up my list of articles here that proves the point that medical students become proficient in goal-directed echo. Okay? The literature sort of peters out in the late 2010s simply because it was a proven concept. So don't worry about that with proper training. By the way, the American Society of Echocardiography now has position papers on the subject which say this is all right for properly trained non-cardiologists to do. So don't worry about that at all. This must be another one. He had end-stage renal disease, dyspnea, hypotension. So always hypotension was sepsis, right? Okay. We did a goal-directed echo on this patient. And here we have the parasternal law. For those who do a bit of echo, you can see there's a circumferential pericardial effusion. By the way, the LV function is fine. There might be a little bit of aortic dilatation that turned out to be not relevant. Valve morphology is all right, but pericardial effusion also present here, circumferential. And we became rather concerned here because in the apical 4 is circumferential, and you'll see in a moment that there is significant chamber compression. And of course, this was not just a simple sepsis presentation, but rather it was uremic pericarditis. The IVC was dilated, which is consistent, but not diagnostic with tamponade. And red-blooded intensivists do their own pericardiocenteses under ultrasonography. It's always a relief to see when we inject agitated saline contrast that it lights up the fluid and not the ventricle, if you get my drift. Okay, yeah. All right. So that's one defense. Look for the bad stuff, and occasionally you see it right away. The conclusion being that really that's a reason to do goal-directed echo in patients in shock. All right. The second reason is that for many, many years, it goes back to a man named Dr. Weil. He developed this very simple categorization system, right? Where we're supposed to, when we approach shock, we're supposed to say, all right, is it cardiogenic? There are several subcategories. Is it obstructive? Is it hypovolemic? Or is it distributive shock? That's the first bedside decision that we have to make. So you send each of those patients down different therapeutic and diagnostic pathway, right? It turns out that gold-directed echo is eminently designed to categorize shock. Once you rule out that the patient's not going to die in the next half hour, right? Then you just see hypotensive patient. But death is not imminent. So let's see what we can do here. This patient was 45, a renal transplant. Right away, you're unhappy because they're immunocompromised, right? Fever, hypotension, positive UA, elevated WBC, slam dunk. This is a sort of a sepsis bundle type of patient, and patient receives some volume. They got antibiotics right away. So right, maybe we still ought to do it to see if there's something else going on, or So all right. So parasternal, long, sorry, and short. Hey, it's normal. LV function's normal. RV outflow tract normal. No pericardial effusion. Valve morphology looks grossly all right. It's not end-systolic effacement. So you say, well, patient's in shock. The echo doesn't show anything in particular. So let's see what's going on the next one. And likewise, we had a lot of trouble getting a good axis on the apical 4. So the subcostal is sort of like the poor person's apical 4. The RV is not dilated. And the IVC was in an indeterminate range, so we decided no further volume resuscitation, no inotropic support was required. We're going to focus on maintaining, defending blood pressure because this is distributive shock. All right? And then maybe we'll do serial goal-directed echoes to see if there's evolution of something going on. So then you say, well, why don't you do the echo if it was sort of normal? That's the whole point. It may not have been. So just as when we check hemoglobin in a patient in shock and find it's 14, does that mean we should not have done it? No, we're saying, yeah, it's normal, good. All right? So there's nothing wrong with finding normality on an echo, or an X-ray, or a CT scan. Notice that I did not use the word normalcy, which I think was misused by President Hoover a long time ago. Normality, okay? Yeah. So the other reason to do it beyond sort of categorization, but also many of our older patients, our chronically ill patients, have a coexisting diagnosis. Confounder, something that's lurking there that's going to hurt your patient when you've categorized it clinically as one thing, but they have something else going on, a confounder. And does the patient have more than one reason for their shock state or a complicating factor? Yeah. And this is where goal-directed echo can be very useful. So let's see, imminently life-threatening, categorization, and now we're looking for confounding diagnoses. Okay. She had advanced pulmonary sarcoidosis and immunosuppressives. Right away, Dr. Shapiro is not happy. Okay, yeah. Fever, dyspnea, hypotension. Thoracic ultrasonography showed a right lower lobe pneumonia. No chest x-ray required if you're a believer in lung ultrasonography. Okay. The diagnosis quite recently was septic shock with pneumonia. So then some administrator has told us several years ago that we have to employ a sepsis bundle in everybody. Otherwise, bad things will happen to us. We'll be put in like, sepsis bundle jail. It's an interesting idea. But maybe we ought to do a goal-directed echo before we execute in some mechanical fashion what might be an inappropriate bundle. Okay, so let's take a look at this case. Whoa, parasternal long, normal LV function, we're happy, but the RVOT, the right ventricular outflow tract, is quite dilated. Dr. Matthews notices that the coronary sinus is dilated. There's no pericardial effusion. So right away, we're concerned the patient might have a right-sided problem. On the parasternal short, we have the dreaded D-shaped ventricle. See, the septum is compromised both in systole and diastole by a very large RV. This patient is dying with normal LV function, right? It just can't fill because the RV is encroaching on it, okay? So the apical 4 was of grave concern, a very large RV, a very large RA. There's constant bowing of the intraatrial septum into the LA, meaning right atrial pressure is very high, causing the dilation of the coronary sinus. And the LV is very small. And that's the whole point. In this type of patient, as the RV gets bigger and bigger and bigger and bigger, pericardial constraint, the rule holds, the LV gets smaller and smaller and smaller and smaller. It can't fill. And what happens if you give volume resuscitation in a mechanical way to this type of patient? They get more hypotensive. So I would advise never give volume to a patient, any substantial quantity, until you rule out reasons not to give it. For example, in this patient. So we immediately turned off the volume when we saw this, right? And then on the subcostal, we have a thick RV, so this has been under load. This is an Arnold Schwarzenegger RV, okay? All, and of course, it turned out the patient had severe pulmonary arterial hypertension from the sarcoidosis. And in addition, they had septic shock. And then in addition, they had a big pulmonary embolism. That's 3 things, all right, that each requires a different approach, okay, a different treatment plan that occurred in a patient who initially was just like, sepsis, give volume, give antibiotics. So there's another reason to look for coexisting or confounding diagnoses in patients with hemodynamic failure. The typical ones are you do a study in an old patient, and they'll present with sepsis, nursing home and whatnot, and then you find they have tight AS. That's a tiger by the tail, right? Those 2 things, distributive shock with a bad valve stenosis. You got to know that. Vasoplegic shock, I've showed you that with pericardial tamponade, P. Ventilators need to be carefully adjusted in patients who have hemodynamic failure and association with right-sided dysfunction, et cetera, et cetera. So case number 7, she had gram-negatives in the blood. Like this was real septic shock from a UA, elderly of course, started on sepsis bundle because again some misguided administrative rule says 30 and then another 30 in everybody, otherwise you're going to be dinged. No. We say do echo first and then make the decision based on what you see. Some people need it, some people don't. So she was mottled oliguric and slow capillary refill, increasingly dyspneic. What? We did a physical exam? Of course, right? If I hadn't done a physical exam in detail on every patient in 1979, Dr. Beautyman would have really given me a hard time. I still remember that. Okay, so let's take a look at this one. So, she's given the antibiotics and stuff. So now, is this advancing or are we stuck? Yeah, we're stuck. So let me see if I can get us out of this stick. I'll try to find my. Okay. Let me back up. Oops. So what we found was, in addition to the obvious sepsis, on parasternal log, she had severe LV dysfunction. In addition, you see incidentally a pleural effusion, which would be further characterized automatically with a look at the thoracic compartment. The parasternal short shows severe LV dysfunction. The apical fork shows severe LV dysfunction, as does the subcostal. By the way, there's a pseudo pericardial effusion. She had some ascites that we detected here, so we took a look at that with abdominal approach a little bit later. And it doesn't surprise that the IBC was large. And of course, we did lung ultrasonography and found what are known as multiple profuse B-lines. Those of you who know a bit of lung ultrasound will recognize immediately that with severe LV dysfunction, with profuse alveolar interstitial abnormality, a dyspneic patient, after receiving inappropriate volume resuscitation, the patient had developed iatrogenic cardiogenic pulmonary edema. So that's a reason to look for reasons to do stuff or not to do stuff because of coexisting diagnoses. The diagnosis, of course, was severe LV dysfunction with vasoplegia from distributive shock pattern. Antibiotics continued, discontinued volume resuscitation. We measured their cardiac output with echo, which is another discussion. Started dobutamine as a result, balanced it with phenylephrine to avoid much hypotension, and diuresed the patient with sepsis. Of course, we had to. Okay. Sepsis bundle, not to harp on it, implies that one size fits all. I'm looking around this room, and I don't see any twins here. Each of you look very different in size and physical aspect and gender, ethnicity, race, so here are these people telling us that everybody is the same. I'm just asking, right? So that's another reason. Coexisting, confounding, categorization of shock state. And then another interesting reason to do it is that you can do serial goal-directed echoes really easily. Dr. Matthews, when you get going, when you're not teaching people, bet you can do one in about a minute, minute and a half. It's like not rocket science, yeah, okay. So sometimes it's worth looking, serially, what's happening to the heart. You can do that on an acute basis with a little bit more skill. This is beyond goal-directed echo. So in my unit, when we start dobutamine, we don't turn it on and come back a day later to see if it worked, right? Instead, you do it properly with what's called a dobutamine trial. Meaning you measure the stroke volume with no dobutamine, and then you increment the dobutamine, and then you measure whether it actually works. And without going into details, we saw here an increase in stroke volume with dobutamine. Finally, the final dose was 15 of a good 60% increment. That was done every 3 minutes that we follow this. That's for immediate response to therapy. You can do it with patients who have severe pulmonary hypertension, if you're starting nitric oxide, things like that. But also, the other reason is very, very interesting that sepsis cardiomyopathy occurs in about 20 to 30% of patients with sepsis, according to the best literature, and it's fully reversible. So here is the patient, severe LV dysfunction with proven sepsis, and 2 weeks later, completely normal LV function. And imagine if we had discharged the patient from the ICU. Patient has severe LV dysfunction. They'd be on a beta blocker. They'd have an AICD put in. They'd be on ACE inhibitor for the rest of their life. This patient had transient LV dysfunction, and therefore they didn't need lifelong therapy for it, right? So it's a reason to think about sometimes repeating not only see effective therapy immediately, but also what is the natural history of the effect of therapy or just spontaneous recovery on cardiac function? What about a complete echo? Gold-Reck echo never, ever replaces full echo. Okay? So I have that in red. Does not. When indicated, when the team feels Gold-Reck echo is not sufficient, you call an expert, cardiologist, right? In the light of day. And they're extraordinarily helpful because they're super experts, okay? So don't hesitate not only to know what you can do with a result, but also what are the limitations of Gold-Reck echo, and then if there's further concern, give the call to the experts. I'll remind you that never exists alone. It's always combined productively with lung and pleural ultrasonography, with sometimes vascular diagnostic, looking for DVTs. Obviously, all procedures that we do in any of them should be guided with ultrasound. Abdominal is quite useful, but always for the house staff, always, WUBU must be combined with history, physical exam, and analysis of laboratory values. It can never stand alone. And then that allows you to combine what you know about the patient with the WUBU results. It's a powerful integration of imaging and also with the classic diagnostic tools you use at bedside. WUBU was never performed in vacuo. I get to use in vacuo once with every lecture. Notice that I italicized it, which is proper. I still hear the same tired. Dr. Matthews, you sort of get this little bit of pushback sometimes. So let's go. Okay. Always the argument comes down to there is no evidence that WUBU improves patient outcome. Therefore, why do it? Which is a reasonable question, right? So the first way to answer that is that the use of X-rays, CT scans, and MRIs in the ICU have never been subjected to evidence-based medicine, ever. They're accepted intuitively as useful. So why focus on ultrasonography? It's just another imaging modality. It's been fully validated by our colleagues, right? So that's one argument. And then the other argument is that I would maintain, I hope you agree, that the entire edifice of modern medical practice, boy, I sound old, don't I, rests on the concept that if you know the diagnosis, you could help your patient. Does anybody deny that here? No, you don't even think about it, okay? So if ultrasonography allows you to make a diagnosis, logically, unless you deny all of modern medicine, it has to be helpful. I sort of like that argument, okay? Finally, if you're having a little rough time, you're in a polite way. By the way, do you do critical ultrasonography? That usually ends the subject, okay? Now, okay, Dr. Matthews is listening carefully. For the more adventuresome here, who are going to be doing hospitalist work or aimed towards critical care medicine, the National Board of Echocardiography is now offering national level certification in advanced critical care echo, not Gold-Reck echo. And this is a big cooperative project with CHEST, ATS, SCM, ASEP, ASA, blah, blah, et cetera, The National Board of Medical Examiners writes the exam. It's given in these horrible computer centers that we go to, right? We're all fingerprinted and stuff like that and searched, yeah. I just took my 4th critical care recertification exam. Dr. Shapiro, I passed it, don't worry. Yeah, okay. And I was in the group that they required me to remove all my clothes when I went into the room. Yeah. So this is this is totally new, but it is totally like big business. Okay. The first examination, 15th of January. Some of the ICU staff in your system took it, actually, yeah. And there were 506 crazy intensivists who took the exam. I was astonished, okay. Now they're facing the challenge of a very, very severe image acquisition requirement, very severe. And if any of you are interested in this process, the fellows in particular, you have plenty of time to train. You have no conceptual barriers to this idea. You're very patient care orientated. You want to excel. And for professional development, believe you me, for the fellows who are listening, this will be an powerful incentive for clinical academic programs to hire you, because you'll have general body ultrasound, but also advanced critical care echo. That's a powerful combination for professional development. For attendings, what we found in our analysis of why people take this, enter this, is that a lot of attendings want to verify their own capability. Sometimes they have practice. For example, they work in a CT ICU full time. A lot of attendings do it because they have this attitude: there's a mountain, I'm going to climb it. It's a big mountain. They just have this crazy attitude, a desire to learn, also professional development. And I think if we had 506 this year, there's going to be more next year. In the future, probably as more and more ACEs come out, it will largely replace ICU. We have no interest in other types of echo. But the cardiologist in my unit, where we have 3 or 4 people who are fully qualified, if we see an artificial valve, any decision about valve surgery, complex congenital, strain, intracardiac echo we are experts, okay? So I think that's how the field is in the ICU. The paradigm here, that's me. I'm a bit of a cone head because the photographer was a fellow. He used one of these wide-angle lenses, and you think I might be scanning a patient, but in fact I'm scanning one of our top guys, Jose Cardenas. He's Peruvian. You know Jose? Yeah. Yeah, he's an IP, yeah. And notice he has a wonderful tattoo. And he was a fireman in Lima. And in Lima, the firemen, they're very proud. They place these rising from the flames. So this is not a sociopathic tattoo at all. Notice that we have our ready to go in certain circumstances. Right here, okay. We have our best friend, our video laryngoscope. And of course, this old attending is thinking, I've done the history, I've done the physical, but I'm going to do the ultrasonography immediately, repeatedly, and in routine fashion. Okay, that would be the model. Younger generation. If the old guy does it, the young guy and gal can do it as well. Okay? So I have 12 minutes. I didn't know how long this would take, this one, but I have another brief through to sort of drive home the point.
Actually, we end around this time. So
we do?
Take questions.
Okay. Yeah, all right, good. So Are there any questions here? Was that crystal clear? All right. Dr. Matthews, what's the resident activity with ultrasonography? I know they are fully trained, et cetera, but one of the controversies that we've had at my place is whether we should try to train 64 interns and 98 residents to be skilled. And we made a decision that it would be unwise, that we should instead focus all training effort in residents who will actually use the. What have you decided to do over here?
Right, so those are some of the challenges here.
Yeah.
Meaning, what gives someone the license to drive or the license to ultrasound? Because obviously, when you drove home, that in the wrong hands, can lead to misdiagnoses and so on. So here, all our fellows, all our critical care fellows, obviously go through the residence. There's a 2-week elective that some choose to do.
That's exactly what we do. We say, look, we'll offer 2 weeks or 1 month of intensive training. Generally, they're in their 3rd year, and they're doing something where they're going to use it. Yeah.
We've had about 20 plus residents go through the including NSUH residents as well.
Yeah.
And for the residents, Nick Paxett, who's over at Beth Israel and DPAN, who's here, they've actually piloted a training program on lung ultrasonography where basically our residency goes through a 6-week cycle for clinic. And during those 6 weeks, they come to the sim lab. So when they come to the sim lab, in addition to a simulated case, they get a 1-hour crash sound. So that's something that all our categorical residents go through. I think it's been pretty well received and successful.
And I'm sure you also focus effort on vascular access guidance for the residents. That's
echo opens
and
up
peripheral stuff.
Worms.
Yeah, so as well, which is to offer training as or for people who are interested in 2 weeks or a month of training. Some get quite good at it. That's what we find, and then they take it into fellowship years. Yeah, it's interesting. And the other question is, what have you guys? What's your response going to be to this revolution of the micro devices? Because that's going to be very controversial. May I introduce this concept? Yeah. We all are used to these sort of computer size, using M turbos, right? They roll around on wheels, etc. They're the workhorse in New York City of scanning. But we all know that there are never enough of them around. And then if you run into an RRT, it's going to be a hassle to take that upstairs. So now the revolution has occurred where the big companies have miniaturized the machines. But called Butterfly. And have you tried the Butterfly out?
Yeah, I've heard a lot.
I think Paro has one. Yeah, and it's just extraordinary. It's a single probe, little large, that combines vascular, abdominal, and cardiac. It's like, what? We didn't think this was possible. And it attaches to an iPhone. It can project to internet connectivity, and I believe it can cast to the machine, so that if you were scanning there, it would come up on the screen. It says, what? So then the revolution is $2,000. So all of a sudden, the enterprising resident or attending or fellow, instead of going for Aruba next winter, they're going to buy a machine. It's like and the cost will fall. So how are you guys planning to deal with the first couple of people who just show up with these machines? They're not even a machine, they're just this little thing in their pocket. What are you going to do? We don't know yet.
Yeah, there's no official credentialing process for this.
One possibility is you can't use it in the hospital. Yeah, the other would be, if you have one,
you can't use your stethoscope.
Don't use. Yeah, so we don't quite know to know, but it's going to be the revolution is coming. Yeah. Dr. Shapiro, have you made a policy decision about that? Not yet. Yeah, it's going to be interesting. Yeah. All right. Any other questions?
Yeah, at the St. Luke's site, a couple.
Oh, I heard this voice.
Thank you for a wonderful,
Yeah.
wonderful discussion. You sold me, it's malpractice not to have it, right? But because you missed a diagnosis. So on the other side of this, though, what is the frequency of error that leads to a less than ideal outcome? So there's no procedure in which errors aren't made. It's just human not to have errors. So I wondered how the frequency is. The other is, how do you store your images? Do you have an iCloud system where you store them so you can review them? Because part of the learning experience is reviewing things.
Absolutely.
And sometimes having people disagree with the interpretation of the same image, and it's an important thing to determine what the elements are that go into that. Finally, part of the problem with a lot of this stuff is reimbursement. Now that this is the extended stethoscope, you will not be reimbursed for an outlay of funds, which the older machines are more expensive than the newer promises, even if you're willing to give up the vacation movement. So those are the issues, and how do you standardize for performance, adequacy, etc. The boards are one way of doing it. But I don't know, are the boards like a practical? We have to look at.
They're very demanding.
And then interpret them.
But those are only for advanced critical care echo, which is a small part of this. Let me see. The first is, what about errors, right? So a guy named Mike Bladis, who's a big ED guy, a couple of years ago, he went and he looked at all closed settlements on the EM side, where they do a lot of ultrasound, for malpractice settlements related to EM ultrasonography, which is very much like ours. And he couldn't find any except for one case. This was throughout the United States in some period of time. He got into their big database. And that was a successful suit for not performing it. Isn't that interesting? Yeah. So you raise an important point, which is with the proliferation of machines, that the great risk is that people who don't know what they're doing are going to be doing the exams, and that'll be catastrophic, right? It'll really bring discredit to the field. So we're very concerned over at CHEST how to keep up with the education requirements so that it's not a disaster when people start doing this more and more. So you're absolutely right. It's all about training and determination of competence and maintenance of competence, and those systems have to be developed. Then the second question relates to reimbursement. And the AMA has this committee that controls, like a lot of, in this weird way, a lot of what CMS does. It's a complicated system. Back in the mid-90s, there was an enormous fight between EM and radiology over whether EM could bill for radiology. And AMA committee issued a standing order, which is any licensed physician in the United States of America, regardless of specialty, as long as they knew what they were doing, and they didn't specify how that was determined, but basically anybody can bill and be fully reimbursed for ultrasonography in the United States, as presently, that's the present regulation. So not well known is that family practice people do a lot of ultrasound. They're fully reimbursed. So we, in our practice, we reimburse all the CPT codes, we wrote the appropriate note, et cetera, and we're reimbursed. So you go to an administrator and say, hey, because all they're interested in money is those folks over at LIJ North Shore, Northwell, they told us that they brought in some money for this. They'll give you another machine instantaneously. That's what they did to us once we got revved up. It brings you incredible credibility with administration if you have an efficient billing and collection system. It's the ugly truth, But so that shouldn't be a concern. Now, in terms of the memory or Joe, what do you use here? Are you connected to QPath? Yeah, QPath. That's pretty universal in the city because we've had terrible problems getting attached to PACS. That's a whole other discussion. But most of the ICUs do a lot of ultrasound in the cities have a cloud-based hard drive, HIPAA compliant, which is very easy to use. You finish your study, you hit a button, and it's transmitted virtually instantaneously to a durable digital image format that can be used for review, and so that would be absolutely necessary if you're going to run a good ultrasound type program. You have to have QPath or something similar. Yeah. So does that answer the 3 questions? I hope so. Yeah. All right. Anything else, Joe? No. Okay. Do you have a moment to talk, or you have to go up to the ICU now? Yeah. I just want to catch up with you. Okay. Thanks a lot.